We feel really privileged to have the Australian Girls Choir here this evening. Our daughter Daniela was a leader in the Australian Girls Choir, and this is a wonderful tribute for her in Sydney from the girls to be here and join us tonight. So thank you, girls, you did an amazing job, and we are all Australian. I'm very proud. Thank you. We're so pleased that you've all come to join us this evening. We've got a great night planned. I would especially like to welcome Tony Wind from the Health Department, who joins us tonight from Canberra for our event. Thanks, Tony, for coming, and thank you to you and your team for your amazing support of the Danny Foundation and most especially the Type 1 community. Special thanks also to Tanya Stofanoff, our board member who joins us tonight and in support of our national roadshow. So thank you for coming along tonight, Tanya, and for what you do in helping us with the Danny Foundation.
It was the 17th of March 2015, and these words are etched into my mind forever. I am so, so sorry. Your child has type 1 diabetes. You need to take him straight to hospital. We took him to Westmead Hospital and the waiting room was full. We booked him with the clerk and we took our seat. Within 3 minutes we were being treated. If nothing else, type 1 gets you served very fast. Within the next hour or so, the first of a zillion needles started. Bloods were taken and type 1 was confirmed and we were given a bed. It was all a nightmare. Thankfully, due to me recognising the signs of type 1 diabetes, my son only spent one night in hospital. That night and the months that followed were a blurry nightmare, and you all know if you've lived with it. The injections, the finger pricks, the screaming, the restraining, all to make my child conform to this new existence. For those who have been through it will know exactly what I mean. Our daughter, then nearly 8, watched helplessly, trying to console him and trying to make his life better. Heartbreaking pain for everyone. We're grateful that our daughter Ambly is always keeping an eye on him. Us T3s, as I like to call us, our name for carers of T1s, never get to rest, no matter your age, and it was a massive adjustment for all and a traumatic one. Amazingly, he's never complained once, and a credit to his amazing inner strength that I wish we never had to see. Would you like to sit down now? Would you like to sit down now? Thanks, Mum. The hospital and clinic kept telling us it was like having a new baby. I didn't really like that analogy, and I still don't. New babies bring joy, and there was no joy in this. What they failed to tell you about this new baby phase was that it doesn't get any better, and the new baby phase doesn't end.
So what is CGM? Continuous glucose monitoring. Okay, so there's a very small device that you wear on your skin. So Belinda's actually wearing one on her arm, and I thought it's much easier to see than it is on the slide. So that white button on the arm there is attached to a sensor which sits in the skin. So there's a little hair that sits under the skin there, and basically that measures changes in the electricity that different glucose levels give the blood. So a glucose level of 4 has a different electrical property than a glucose level of 20, and this little hair in the skin picks up that electrical signal and sends it to a device such as a smartphone or a receiver or an insulin pump where you can look at your glucose levels basically. The CGM can also therefore alarm and tell you whether you're high, low, or about to go high or low. So here, this is what I'm talking about. The little white button that you saw on Belinda's arm is this part here, and this is the little hair that sits in the skin there. Now, that number can be beamed to different devices, either a watch, like Catherine showed us, a smartphone, or an insulin pump. So again, Annette's wearing an insulin pump, and if she had her CGM on today, she could look at that and see what her glucose levels were doing. It also provides people with an idea of what's going on with their sugar, whether it's going up or down, or if it's staying stable. And all of those situations give us different responses. So compared to finger pricking, what we've got here is a graph to show what somebody who's not wearing a finger prick would do, as in these red dots here are the glucose levels that you'd see if you prick your finger. Now, you can see here that this is a glucose level of, say, 6. And when you prick your finger, you don't know whether that's a 6 and is stable, a 6 that's going down really fast, or a 6 that's going up really fast. And those 3 different scenarios could lead to 3 different responses. So if your sugar is 6 but it's going down really fast, you might decide to have a couple of jelly beans or a bit of juice to nip that in the bud to stop it going down. But if it's 6 and going up really fast, then clearly you wouldn't do that. You might take another approach. So a CGM fills in these gaps basically in between the times when you would normally do your finger pricking. So clearly this person here might have had something to eat, seen a big spike in their glucose levels, and might have made a decision based on that number there. And if they hadn't have known what was going on there, they wouldn't have been able to act and treat it appropriately. And again, what the CGM can do is pick up these lows that you might miss in between your finger pricking. So for example, if you go to bed with a sugar of 8, you don't know what's going on overnight until you do your next finger prick. But this gives you some information during the night, as Donna and Catherine have explained.
When Donna asked me to do this tonight, I was actually quite apprehensive. As you can see, I get really emotional when it comes to talking about Caitlin and her diabetes. I always end up a bawling mess. I am the mother of a diabetic child. I don't know what it's like to go to sleep at night and know for certain my child will wake up in the morning. I don't know what it's like to sleep the whole night through without waking up to do blood tests on my sleeping child. I don't know what it's like to prepare a meal without a calculator, measuring cups and a set of scales. I don't know what it's like to drop my child off at school and know she'll always be in the charge of someone who knows how to take care of her. I do know what it's like to force feed sugar in the middle of the night knowing I am sacrificing my child's teeth to save her life. I do know what it's like to drop insulin at 2 a.m. and pray to God I'm not too sleepy to make a fatal error in judgment, technique or calculation. I do know what it's like to sit underneath the dining room table holding my sobbing child, explaining to her, "No, sorry, we can't take a break just this one time," while I inject into her already bruised body. I do know what it's like to walk away from the chemist with an armload of supplies and realise I've just gone through another box of 200 syringes. I do know what it's like to help my child march bravely past the juice and cookies at the school reception that was supposed to be her reward for achieving Student of the Month. I do know what it's like to look into my child's eyes and tell her she is an incurable disease and explain to her what that means, and then to be comforted by her when I'm the one who can't stop crying. I do know what it's like to love and cherish my child every minute of every day, to know that I may someday donate a kidney to her, and that if she was in need of a heart, mine would be out of the question because it broke a long time ago. I am the proud mother of a diabetic child.
Just a recap on HbA1c. So this, as you know, is the special test that you get done every 3 months or so when you see your healthcare professional. And the numbers across the bottom there just show blood glucose levels in millimoles per litre. The white numbers on top of the rainbow show your percentage, your HbA1c, just to show you to what they roughly correlate to. And as international standards change from time to time, everyone's becoming aligned to millimoles per mole, so those blue levels on top, which I won't talk about today, we'll just talk in terms of percentage. And you can see that if in the middle of the graph there, if your blood range is between 10 and 14 on average, these aren't individual blood glucose levels, this on average, if you're falling in that range, then your HbA1c, when you get it checked, is going to be about 9%. And we really should be aiming towards the less than 7.5%. So you're talking about having blood glucose levels that are in the single digits rather than double digits. And if it temporarily and very briefly goes into double digits but then comes down, it's not going to dramatically impact on your HbA1c. But if it's persistently elevated, obviously, that's when levels are high. So we really need to keep those levels down, but obviously not at the expense of having hypos. So with that in mind, why have we picked 7 or 7.5 as the magic number? Why are we aiming for this, and what's the significance of all of this? So the boring sciencey bit goes back to the early 90s. So the Diabetes Control and Complications trial, which was a pivotal trial that linked HbA1c to the risk of diabetes complications. And so the study was actually started about 10 years prior in 1983, where they got just over 1,400 healthy volunteers aged 13 to 39. And they had them in two groups. So one group was on conventional diabetes treatment at that time and actually had an HbA1c of 9%. So today that would not be a conventional treatment group, just to show the difference in treatment over time. But back then that was considered a good result, versus an intensive therapy group where the aim was always for near normal blood glucose levels, and they had a mean HbA1c of around 7%. And as you can see from the graph, as your HbA1c increases, your relative risk of various complications also increases. So if your HbA1c is above 10%, you're at almost 10 times the risk of the general population for having diabetic retinopathy. And as is sometimes seen, in the less compliant teenagers, HbA1c is above 14%. You can see it's off the scale on this, but a greater than 20 times risk of eye disease, as well as nephropathy and kidney problems and nerve problems. But what's come out of this as well is you need to have not only good control early, but you need to have good control for a long period of time. Over recent years, the EDIC trial, which is the Epidemiology of Diabetes Interventions and Complications study, was reported on. And this is a 27-year follow-up of all those patients that were in the original DCCT trial. And there was no intervention during this time. They were just let back into the wild, left to do whatever. And the HbA1cs between these two groups was actually the same. There was no difference between these two groups over that 27-year period. But what was found is that if you were in that original tight control group, you had a 50% reduction risk in getting kidney problems, and a third reduction in mortality just from having early good control, irrespective of what happened. So really highlighting the point that we need to get on top of things early and for a long period of time, chronically. So the overall aim is to avoid these long-term complications, and that can only be done, or it can be helped with technology. And CGM has been shown to reduce your HbA1c by at least 0.5%, and some studies greater than 1%. So the benefits, obviously lower HbA1c, less finger pricking. So on a day-to-day level, that's what obviously lots of our paediatric patients enjoy the most. The families get notified of when blood glucose levels are in dangerous levels, which is worth its weight in gold. And as you've heard from the previous talk, the freedom and quality of life that ensues is also immeasurable. And it helps to really identify on a minute-to-minute, hour-to-hour basis what influences your blood glucose levels. What impact does illness, what impact does food, not just the carbohydrate, but the fat content, the protein content of the food that you're having, what impact does that have on your glucose levels? And therefore you can tailor your treatment to really maximize the time that you have within that ideal range. And most importantly, the fear and the reality of the dead in bed syndrome that so many parents have to live with. There is no other tool that can help defeat that.
All we wanted was a happy, healthy girl that just took on looking after her diabetes as easily as everybody else we've met in that situation. We were not in a good place. It was at one of our 3 monthly clinic visits with our endo that the most impact was made, on me anyway. We'd been seeing Dr. Howard for a very long time, but on this particular visit he was very down. His words were, "We lost another one this week." I remember not completely understanding what he was talking about, what levels this girl had gone to bed with, and a few other details. Similar age, similar length of diagnosis, typical teenage stuff. I thought, I'm confused. Are you talking about this girl he'd just lost, or are you talking about my daughter? And he simply said it was very hard to tell. I remember thinking, well, what do you mean? Could this happen to us? not realising what that actually meant. Surely after 9 years, and sure, we're not great at it, but really, could this happen? You told me that there was technology that could prevent this. You told me he was concerned for us. You told me I needed to talk to this girl's mother. They're going to do wonderful things and make this available for all type 1s. You really urged me to make contact. So I went home, I wrote an email. It was a very condensed version of where we were at as far as our type 1 was in our family and how it was totally taking over our family, our life, and not in a great sense. This email was sent to Donna. I received a reply almost instantly, and later that night I had my first conversation with Donna. It was a conversation of both joy and sadness. Sadness in the sense I was talking to a mum who had lost a daughter. Joy with the offer for her to help us. Joy that this woman was understanding our struggle. In January 2014, Emily and I went on the inaugural Jelly Bean Cruise. I thought it'd be a good way to start the year. Just mum and daughter. We would meet the Meads Barlow family, we'd have a nice time. Bit of mum and daughter time. And what a life-changing experience that cruise turned out to be. I thought after nearly 10 years of living with type 1 diabetes, there was nothing new to learn. And wasn't I wrong? I learnt new information. They talked about this technology, some alert technology that could almost eliminate finger pricks. This new technology would enable us to see BGL levels at a glance. This technology would allow us to sleep. This technology would give us peace of mind. This technology is called CGM. It was also on this cruise where we decided to wipe the slate clean and start afresh with dealing with Em's diabetic care. Em might have been convinced with a little chat her and Donna had, but I'll let them tell you that story another time. Not long after the cruise, my hubby and I decided to bite the bullet and purchase CGM, and as you know, it isn't cheap, but we were prepared to give it a go. I remember sitting on the lounge after the 2-hour start-up, just staring at the receiver, watching the trending. It was like being able to see what was happening inside her body, there and then. And Em sat there looking at the trending going, "Look now, Mum," every 5 minutes. "Look now, Mum." And this went on for about an hour. I remember sitting in awe of being able to see what the trending was doing without arguing with her with the old, "What's your level?" CGM technology allows you to see so much more information.
And most importantly, there is a brochure on how do I access continuous glucose monitoring and the eligibility and the process. I'd like to assure you that the access is about eligibility. I know that there's a lot of worried parents out there. It is that the access is about eligibility and it is not capped. So please don't worry if you do not have an appointment with your health professional in the next week and not even for the next 3 months. It doesn't mean you're going to miss out. So please do bear that in mind. So in brief, I would like to just walk you through the eligibility and what the process is. So first and foremost, you need to be registered with the NDSS, and if you are not, then you need to go through your health professional or your endocrinologist to assist you in that area. You then need to fit into the eligibility for the eligibility criteria that is noted on the form. I recommend that you go to the NDSS website, which is within this, and download the application form and partially fill it out. It certainly is helping our health professionals out there in the field if they have a form that is partially completed when you go in to see them. This form then needs to be completed by the rest of it by your health professional. your authorised health professional, who will then contact you who will then submit the form. After that, you will receive an email advising you if you have been approved, and then your health professional will make an appointment with you for your continuous glucose monitor when it has arrived, for you to come in to have implementation and training. From then on, you will collect your sensors from your local NDSS access point as you would normally with any other diabetes consumables. If you already have continuous glucose monitor, then you will follow the same process, meeting the eligibility criteria and completing the application, and again, once approved, you'll be advised, and you would then collect your sensors as you would normally from your NDSS access point. Please do remember to back up this session with the advice and support from your usual diabetes health provider. And remember, this information is about eligibility, and the program is not capped, so please don't worry.